introduction, Scott, and I want to thank the organizers for inviting me to this meeting. This is my first time here, and I'm not going to talk about basketball because it's probably going to jinx our Florida team if I do. But let's start here with the title, and the title is The Identification and Prevention of Necrotizing Enterocolitis. And as you'll see through this lecture, that this is really not exactly what I'm going to be talking about. This is actually a little bit to the side of what the major thrust of this lecture is going to be, and you'll understand why as we go through. Here's my disclosure slide. I do have relationships with several companies, and I think the closest one that comes to the lecture is this infant bacterial therapeutics that Scott mentioned. This is a group from Sweden that is supporting this trial. We have over 2,200 babies involved in this study from 95 different neonatal intensive care units in 10 different countries. And I'll talk a little bit about that. Now, I'm just going to show you this slide here. This is a quote from Anton Chekhov. Then I feel so happy and at the same time so sad, it's unimaginable. And what am I alluding to here? Well, I'm alluding to something that happened September 19th, 2024. And the National Institutes of Health recommended strategies for advancing research on necrotizing enterocolitis. And that got me very excited because it sounded like some money is going to be put into this project, and this is very much needed. But the problem is that when you talk about necrotizing enterocolitis, we are not talking about one target. We are talking about several different targets. And this has been a major problem over the last several decades in our not being able to make progress. And if you look at the 17 different projects or types of areas they talked about, more than half of them had necrotizing enterocolitis as the outcome. So for example, what components of human milk will decrease necrotizing enterocolitis? Well, this is highly problematic because I think that some of us, myself certainly, do not think that necrotizing enterocolitis is a distinct disease, even though we are calling it a distinct disease. It's sort of like diabetes. You have type 1, gestational, and you have type 2 diabetes. You call all of them diabetes, but the pathophysiology is very different. And the same thing holds true for what we are calling necrotizing enterocolitis. And if we don't begin to recognize that and have a better understanding of the different categories or clusters of illnesses that we call necrotizing enterocolitis, we're going to continue to keep on digging into the same hole. And that's why I was sad when I saw these 17 different areas that they were talking about in this particular initiative. Now, I'm going to just give you a quick quiz, and I'm not asking for any loud answers, any oral answers. I'm just asking you to think about these. Number one, please define necrotizing enterocolitis. Number two, is necrotizing enterocolitis a distinct disease? Number three, do babies with Bell's stage 1 or 2, quote, NEC, have intestinal necrosis? Do we have a clear understanding of the pathophysiology of NEC? Do we have accurate biomarkers for NEC? Are there clearly effective preventative strategies? And lastly, should we start over again and redefine intestinal injuries and feeding dysfunctions that we are calling NEC? So let's start here with a little bit of history. And back in 1965, Dr. Alexander Schaefer published this textbook called Diseases of the Newborn. And in the 1965 edition, nothing was said about necrotizing enterocolitis. 6 years later, Schaefer and Avery's textbook, Diseases of the Newborn, had about a small paragraph, about necrotizing enterocolitis. And as you all recall, over the last several decades, we have been saving more and more small babies, and this is around the time between 65 and 1971 when neonatology was actually started as a discipline. And since that time, we're saving more and more small babies, and we're starting to see certain problems that we never saw before in babies because we are saving these babies now. So here we see this preterm infant being mechanically ventilated, and a few weeks later, something happens. Baby has a very distended abdomen. Baby was taken to surgery. The entire bowel was dead. This baby ended up dying. We have not made very much progress with this problem that we are calling necrotizing enterocolitis for over 60 years. And I conjecture that there are several reasons for this, and the three probably top reasons are: number one, we lump several distinct diseases into what we are calling necrotizing enterocolitis. We are putting this all into the same data set, and our data sets that we have in this problem are garbage. Animal models do not correctly represent what we see in human preterms. And last, we have a large focus on individual pathways. For example, a toll-like receptor 4 pathway. People have put their entire careers into looking at the toll-like receptor 4 pathway and how we could utilize that for the prevention of necrotizing enterocolitis. Well, we are now knowing that there's a lot more to it than any single pathway. So in 2011, I and Dr. Alan Walker from Mass General Harvard had the opportunity to write this review in the New England Journal of Medicine. And at that time, we invoked this term called classic neck, and I put classic into quotes here. And at that time, we were starting to see that there were several different entities that we were calling neck. For example, there was one entity that had been around for about at least 10 years. In fact, some of you people may actually know the person who first described this, or was one of the first people to describe this. And this was Judy Ashner, who was here in Tennessee for several years. And that was a different disease entity. So we were beginning to think that, okay, we need to invoke something called classic necrotizing enterocolitis. And on this picture, we see a baby with a distended abdomen, some periumbilical erythema. X-ray was taken. We see these two arrows. The lower arrow is pointing to some pneumatosis intestinalis. This is air in the bowel wall. And then the top arrow is pointing to the liver and some air in the liver. This is called portal venous gas. And these are considered to be very distinct harbingers of necrosis of the intestine. Well, this baby continued to worsen, was taken to the operating room, and you can see what was found in the operating room, this area of necrotic intestine. Fortunately, this baby was able to get a reanastomosis after resection, and the baby ended up surviving. But this we called classic neck in 2011, and now in 2025, I'm very skeptical if there is such a thing as classic neck. And so I like to depict it here in this gumball machine. You have these different flavors and different colors of gumballs, and that is what we are calling neck, all of these different entities. So just a few years ago in pediatric research, Dr. Ravi Patel and colleagues published this article defining necrotizing enterocolitis, current difficulties and future opportunities. And I highlighted here, in this review, we summarize 8 current definitions of NEC and explains similarities and differences in clinical signs and radiographic features included in these definitions, as well as their limitations. Well, think about this. 8 different definitions of something. Do we really have a definition? No, we do not have a real definition. And defining a disease is really important if we are going to try to develop preventative measures and biomarkers and understand the pathophysiology. So over time, we are beginning to recognize that there are some entities that we are calling NEC, and I call these imposters, but that's not the perfect term for this. But we have what we call stage 1, 2, and 3. Well, where does this come from? In the late 1970s, Dr. Martin Bell from Kansas, a pediatric surgeon, developed these staging criteria. He did not mean to define necrotizing enterocolitis. He meant to define different stages of severities of intestinal injury. Now, in 2025, if you think about babies less than 750 grams, which we have a lot of now, how many of them have stage 1 necrotizing enterocolitis? Probably all of them. Probably all of them, because they develop distended abdomens. They have feeding intolerance. They have apnea and bradycardia. This is what was called stage 1 necrotizing enterocolitis. That's a total anachronism. And I'll talk a little bit more about stage 2 and 3 shortly. But then we have spontaneous intestinal perforations. We have cardiogenic ischemia, babies with hypoplastic left ventricle, interrupted aortic arch. Those babies don't get blood to their GI tract, so they have an ischemic bowel. That is not the same thing that we are seeing in our premature babies. We have some babies who start to get problems with their bowels once you start feeding them certain kinds of formulas or certain kinds of human milk. So this is food protein intolerance syndrome. This is a different enterocolitis syndrome. So these are real problems that we have. Now, when it comes to the pathophysiology of necrotizing enterocolitis, there's been many studies done on the pathophysiology. And I'm going to talk about these very shortly, but give you a quick warning that when I talk about these, I'm talking about current concepts of the pathophysiology with the problem that we have of not having a defined outcome. So, what about studies in animals? I said that this is a problem. This is actually from some work that I did when I was a fellow back in the late 1970s. And at that time, Drs. Pitt and Barlow at Columbia University developed this model of what they called necrotizing enterocolitis in baby animals. And at that time, we thought that hypoxia ischemia was a major component, pathophysiologic component of necrotizing enterocolitis. So how does this animal model work? Well, you see these baby rats put into this plastic bag. The plastic bag is closed, and you leave them in this plastic bag for 7 or 8 minutes, and they begin to turn purple, blue. They gasp. You take them out of the plastic bag. They start to recover, but you put them into a refrigerator and you subject them to cold stress for a period of time. You take them out and then you gavage feed them with something that is totally different than what they would be getting from their mothers. In some iterations of this model, you also put in endotoxin, LPS, which is a bacterial product. And guess what? We call this a model of necrotizing enterocolitis. There are 250 papers in PubMed using this kind of a model. This is not what we see in our premature babies. So, unfortunately, we don't have a good animal model for necrotizing enterocolitis. Now, what about this nice term baby with that's being skin-to-skin cared for with the mom and this very preterm baby? Immaturity of the gastrointestinal tract is a major component of intestinal injury, as we all know. I'm not going to get into a lot of the detail here, but the term gastrointestinal tract is very, very different than these little 24, 25 weekers that we take care of. Okay, the term gastrointestinal tract makes mucus, has certain kinds of cells that make protective materials. The microbiome is totally different. We treat these premature babies with antibiotics, which wipes out the commensal microbes in their gastrointestinal tract. And so that actually predisposes to inflammatory responses, which is highly problematic. In the paper from the New England Journal article in 2011, we hypothesized this pathophysiology. And this is still a hypothesis, but people are beginning to say that this is actually the pathophysiology of necrotizing enterocolitis. It is a hypothesis. It is not the true pathophysiology. But the way this works is that there's a predisposition that may actually be a genetic predisposition. We see an increased incidence in identical twins. If one twin gets it, another twin has a greater propensity for getting it. Then we have the altered microbiome in these preterm infants, and that can cause an exaggerated inflammatory response, which then leads to necrosis. But again, this is only a hypothesis. Now, when we look at babies who are 23 weeks gestation versus 29 weeks gestation, we sometimes seem to lump these together. A 23-week gestation premature is a totally different little person than a 29-week premature. I see many of you nodding your heads. You know this is absolutely the case. Well, one of the problems is when we ask the question, when is this 23-weeker at most risk for developing NEC versus the 29-weeker? Well, we see this graph here, and this is a graph that's been reproduced with many different studies, and between 28 to 32 weeks corrected gestational age is where we see the highest prevalence of necrotizing enterocolitis. We're not totally sure why this happens, but we think that the microvasculature may play a role, similar to what's going on in the eye. We don't see retinopathy of prematurity until around 30 weeks gestation. The toll-like receptors are at their highest level during this period of time, the late second trimester. And also the microbial ecosystem is changing during this period of time. So the microbiome is something that has been very much implicated in necrotizing enterocolitis. And over the past decade and a half, or 2 decades, we've now had the opportunity to use different technologies other than culture-based technologies. We use sequence-based technologies to evaluate the microbiome. There are 2 major sequence-based technologies. One is called 16S, which you can see on one side of the slide, and the 16S is relatively inexpensive, and it can give you an idea of the diversity and the relative abundance of certain bacteria present. It doesn't give you an idea of what they are capable of doing. You have to have whole genome or shotgun sequencing to be able to do that, okay? But even the whole genome sequencing, it'll tell you the capability, but it doesn't tell you what is actually going on in terms of interaction between those microbes and the gastrointestinal tract. Well, if we look at babies who develop what we call necrotizing enterocolitis and use these technologies, this sequencing-based technologies, we see different kinds of microbes developing in the gastrointestinal tracts of these babies. So here on this side, can you see the arrow? Maybe not. You see control babies over time and these different colors. The control babies' colors from 24 to 36 weeks gestation are very similar. Okay? These colors represent phyla of bacteria in the gastrointestinal tract. In the babies who develop what we call necrotizing enterocolitis, we see differences over time. The blue begins to increase, the greens decrease, and there's very little of these very bright green that you see at the very bottom. Well, what are the blues? The blues are a phylum of bacteria called the proteobacteria. These bacteria have a lot of LPS, lipopolysaccharide, in their cell wall. They are primarily gram-negative bacteria. Those interact with toll-like receptors, which produce an inflammatory response. The greens decrease over time. These are the good guys that decrease with necrotizing enterocolitis. The bad guys are the blues, the good guys are the greens, and the greens are decreasing. And what are the greens? Well, these are bacteria that are primarily gram-positives that are able to produce short-chain fatty acids such as acetate, propionate, and butyrate. Butyrate is the most important fuel for the colonic epithelial cell. Butyrate also decreases permeability or leakiness of the gastrointestinal tract. If you have a leaky gastrointestinal tract, bugs can get through and cause an inflammatory response. Okay, so those are all positive aspects that we see in the controls, but these are changing in those babies who develop what we call necrotizing enterocolitis. So we are beginning to recognize now, and I'm going to come back to this, that necrotizing enterocolitis comes in different forms. And this is a paper that I'd like you to take a look at if you have a chance. This is a review that was written by Dr. Nina Modi, Mickey Kaplan, and myself a few years ago in seminars. And one of the reasons we say this is that we have a real problem with our data sets. And if you look at our data sets, they are absolute garbage because we don't have good definitions for this problem. And I'm going to get into this just a little bit more on these next couple of graphs, pictures. Here's a x-ray of a 29-week gestation preterm infant. The abdomen is soft. The baby is taking NG feeds well. And we got an x-ray on this baby for not abdominal reasons, but for lung reasons. And the radiologist sent back a report saying in the right upper quadrant, there is this soap bubbly appearance, cannot rule out necrotizing enterocolitis. Okay, so you see this on your report, and what do most neonatologists do? NPO for 7 days, antibiotics for 7 days. That can be potentially detrimental to these babies. Well, what we did in this particular baby, we did not start the baby on antibiotics. We did not put down a tube for suction. We just repeated the x-ray and repeated the examination 4 hours later. This was gone, and it was obviously something that we call pupitosis. Oops. So stool in the bowel can cause this. Okay, this is not pneumatosis, but pupitosis. Here's another x-ray. Obviously something weird is going on here, right? There's a 25-week preterm, 5 days old, on breast milk, on hydrocortisone for hypotension, and develops this distended abdomen. This baby went to surgery, and this is what was seen. No necrosis of the bowel, but a little hole in the ileum. This is spontaneous intestinal perforation. This is a different disease entity than when we have actual necrosis of the intestine. This usually happens very early on. The average age of this happening is around 8 days after birth. It happens primarily in very preterm babies, and putting hydrocortisone or dexamethasone together with indomethacin seems to be a very strong risk factor for the development of this. Do we have an ICD-10 code for spontaneous intestinal perforation? No. we do not have ICD-10 codes. So what do neonatologists put into their charts when we see this? Very frequently, necrotizing enterocolitis is put into the charts. I'd like to just get back very quickly to the Bell's criteria, and I mentioned stage 1 is an anachronism. Stage 2, as you can see from the x-rays that I just showed you, the radiographic signs can be very fuzzy and also misleading. And stage 3, free air on the radiograph could signify intestinal necrosis or spontaneous intestinal perforation, and you may not be able to tell the difference between the two unless the surgeon opens up the abdomen and takes a look. And what do surgeons mainly do? Put in a drain for decompression rather than look at the intestine. Now, many of the studies that we've done on necrotizing enterocolitis, for example, the one that I showed you on the microbiome shows an association, but it doesn't give us any idea about causality. We have a lot of studies that look at probiotics. We have a lot of studies that look at human milk versus formula, donor milk. Well, we have some real problems with this because we don't have a good definition. And when we see these associations, that does not give us any idea about definite causality. And this is problematic. Do any of you know about the lawsuits related to necrotizing enterocolitis? Well, fairly recently, Mead Johnson lost I think it was a $50 million lawsuit, and then there was another lawsuit against the formula companies for $450 million that they lost. And most recently, there was one in St. Louis that actually went for the defendants, and that was for a couple billion dollars. There's over 2,000 lawsuits now in the United States related to necrotizing enterocolitis. And I have to say that I might be partially responsible for this because I've written a lot of review articles, and I've written about necrotizing enterocolitis, and I talk about the differential risk with formula versus human milk. And human milk has less risk than the formulas. Well, does this mean that formulas cause NEC? Well, that's what this has been taken as being, is that the interpretation has been that the formulas cause NEC, which is problematic, obviously. So I think that the term NEC has been misused for decades, and why should we say necrosis when the evidence in most cases is lacking? Do any of you remember the term retrolental fibroplasia? Are we still using that? No. What about hyaline membrane disease? Are we still using that? Okay. Well, I think that necrotizing enterocolitis is a similar anachronism. Now, what about preventative strategies? And this is where we get into the quality improvement issues and what we might be able to do. Well, here we see one baby who's being breastfed, and I think that obviously some of our really small babies cannot do this, but we can still give them their own mother's milk as long as the mother is able to provide that. Donor milk. We think that donor milk might be very protective, but I think that there is room for skepticism, and we need to be a little bit skeptical about donor milk. And the reason I say that is because there have been some studies suggesting that the way that we use donor milk, it may not be the donor milk itself, but the way that we use donor milk may actually have some harmful effects in terms of neurodevelopment. Studies by Debbie O'Connor and colleagues in Canada have actually supported that concept. So we have to be careful, and I think more studies need to be done in that area. And then we have microbial therapies, and I'm sure that you have heard about probiotics. The Question is, are we there yet with probiotics? Are any of you using probiotics in your neonatal intensive care units? Nobody. Interesting. Well, there's countries that have been using probiotics. For example, Australia, Japan, Canada was using probiotics very, very commonly. Canada actually stopped using probiotics routinely after the FDA came out with their statement about close to 2 years ago now that suggested that there were several babies that actually developed sepsis and died of sepsis due to probiotic preparations. So let's just go back in history a little bit with the probiotic story. And in 2010, this paper was published in Pediatrics. This was a meta-analysis of necrotizing enterocolitis in 11 different studies and with 10 different probiotic preparations. All of them were small studies. They put these studies together, and if you look at the bottom, you see that this meta-analysis favored the use of probiotics. Along with this paper came a commentary that said that we now have strong enough data that we should be routinely using probiotics in our premature babies. It is now unethical to not use probiotics, is what this commentary said. Well, think about this. 10 different probiotics in this meta-analysis. 10 different probiotics. Which one should we use? What dose should we use? This did not answer that at all. Now, just about every single year since that time, there has been another meta-analysis. This is one of the more recent meta-analyses, a Cochrane review of 60 trials with 1,156 infants. And I highlighted here what their bottom line was. There is a need for further large, high-quality trials to provide evidence of significant validity and applicability to inform policy and practice. They're not saying that this is enough data now to begin using probiotics routinely. And here, this is a commentary by Brenda Poindexter and the American Academy of Pediatrics. And at the bottom of this, I highlighted the bottom line here. Given the lack of FDA-regulated pharmaceutical-grade products in the United States, conflicting data on safety and efficacy, the potential for harm in a highly vulnerable population, current evidence does not support the routine universal administration of probiotics to preterm infants, particularly with a birth weight of less than 1,000 grams. The studies that we had available in babies less than 1,000 grams, none of them supported their efficacy in babies less than 1,000 grams. Now, I'm going to ask you this question. What is the difference between a probiotic and a live biotherapeutic agent? Well, I'm going to very quickly state that a probiotic is more of a food that has not been adequately studied in the prevention of a disease, okay? It is not an FDA regulatory approved product, whereas the live biotherapeutic product would be one that is specifically aimed toward prevention of a disease, and it has gone through the phase 1, phase 2, phase 3 trials. And so I'm just going to very quickly tell you a little bit about the connection study and its historical perspective first. This started in 2012, and this was initiated by Infant Bacterial Therapeutics. And over time, a phase 2 trial was done, and in 2024, the enrollment of phase 3 was completed, and this was just this past summer. The objectives of the study were to evaluate the first live biotherapeutic agent versus sterile water placebo in very low birth weight infants in terms of safety, prevention of necrotizing enterocolitis, which was the primary endpoint, improved sustained feeding tolerance, reduction in deaths, decrease in severity of NEC, and other pre-specified outcomes such as length of hospitalization, growth, and other morbidities. We had, in this study, 2,117 treated infants, and it was a well-balanced study, and here are the results of the primary outcome. If I can get it. So with the agent versus placebo, we see a p-value of 0.248. Is that considered significant? No, it is not considered significant, okay? Which is problematic and somewhat disappointing, but the problem here is the definition of necrotizing enterocolitis. Let's look at this a little bit more closely. If you look at what we are defining NEC beyond day 14 and take the babies out before day 14, why would we want to take the babies out before day 14? Because of, yes, SIP, because there's such a high incidence of SIP. Most of the babies below day 14 would not have true necrosis of the intestine. So then we take those out and we see a p-value of 0.067. And then if we look at just those surgical babies that were diagnosed as having surgical NEC, actual necrosis of the bowel, beyond day 14, we see a p-value of 0.046. And then when we look at all-cause mortality, there seems to be a difference. And you can see this all-cause mortality between placebo and the agent separating out over time. And there is a 27% difference in mortality between these two groups, with the agent showing a decrease in mortality. When I first saw this, I mentioned to the statistician that this is a secondary outcome. Aren't secondary outcomes just hypothesis generating? And he said to me, just think about this. If it was the other way around, what would you think? We would never consider using this agent. So in conclusion, with this particular study, this is the largest study of a live biotherapeutic agent, and there seems to be a positive benefit-risk ratio in premature infants born at very low birth weight. Now, this is also of interest from the perspective of a Canadian study that was just published last month. And in this Canadian study, they reviewed 32,667 infants born before 34 weeks gestation, and they looked at probiotics versus no probiotics. And there was no difference in NEC or sepsis between the two groups. But they also saw a decrease in mortality, which was very similar to the decrease in mortality seen in the Connection study. They did see probiotic-related sepsis in 31 infants, and 3 of those infants died. So these studies on NEC are problematic, and I have gone through this. Why? Because we don't have a very good definition. There are several different targets here. And so the question has been asked, could we use artificial intelligence and machine learning to better define necrotizing enterocolitis? And this is a study from our colleague Cami Martin, or this is a paper commentary by Cami Martin. And we are able to use some artificial intelligence and machine learning techniques. And one of these techniques is something called unsupervised machine learning. So how does unsupervised machine learning work? Well, let's think about having a bushel full of fruits and vegetables, and they're all mixed up in this bushel basket. And we want to cluster them into bananas, oranges, apples. Okay? We can have algorithms in medicine that can do this kind of a thing for us if we have this large cluster of problems that are still undefined. And this is unsupervised machine learning. This is a paper that we published in Pediatric Research last year, where we did unsupervised machine learning on 200 babies. And this is in one center at the University of Florida. And we had about 30 different features. And what these algorithms do is that they look at these features and cluster them, those features that are closest together. And we can see these ovals at the top. We found 5 different clusters of problems, of different forms of intestinal injuries and dysfunctions. But this is only in one neonatal intensive care unit, and we need to expand on this. I have talked to the National Institutes of Health Neonatal Network. Their data is not granular enough to do this. I've talked to Mednax, I've talked to Vermont Oxford. Data is not granular enough to do this. So I had to go to Canada and the Korean Neonatal Network. And the Korean Neonatal Network has actually got some data already, which I can't share with you yet, but I think it's looking very interesting that in terms of clustering with 20,000 babies. So if we have these different clusters, where do we go from there? Just having different clusters doesn't help us very much. Well, we could begin to look at these clusters, what is going on in each individual cluster, by using something called multiomics, not just looking at the microbiome, but looking at the metabolome, looking at how the patient responds, looking at the phenotype of that particular individual. So we put together all these different omics and we integrate them. And the analogy I like to use is seen on this slide, the 6 blind men of Hindustan. Each one of these blind men was asked to feel the structure. One went to the side of the structure and said, "This feels like a wall." The other one went to the back of the structure and said, "This feels like a rope." The other one went to the front of the structure and says, "This feels like a spear." They all got together, they argued. They did not really integrate their thoughts. If they would have integrated their thoughts, they would have recognized that this was an elephant. Well, one can do this with integrated multiomics. Rather than having an association, when you put them together, you can have causality. It'll tell you what happened, causality, and you put those together, and with that you get what's called a systems biology picture. And in that systems biology picture, you can compare the system that is going on in one versus the other, and you can also pick out certain nodes in that systems biology picture that give you biomarkers that is specific for that particular cluster. So that's where we are going in the future with this. So I'm going to stop here and just talk a little bit, just mention the strategy for the future and one possible approach. And let's just go back in time, back to the 1960s, early 1970s, and make believe that we've never invented the term necrotizing enterocolitis. And think about all these different intestinal dysfunctions that we have, and utilize the tools that we have now available to us in 2025, artificial intelligence, multi-omic integrations, and put those together, and then delineate these with the clinical features, and then find biomarkers in each one of these, and then utilize these biomarkers to detect very early which one of these clusters these babies fall into, and how we can potentially prevent these different forms of intestinal injury. So if we have the biomarker, for example, for a baby who has an inflammatory process due to dysbiosis, could we target that particular cluster with microbial biotherapy? If we have another cluster that is primarily secondary to nutritional problems, milk protein intolerance, could we do things very early on to alter the course of those babies? So I'm going to stop there and thank you for your attention.